So now we have discussed about the conventional mental nerve block, the long buccal nerve block, and the inferior alveolar nerve block. There are also alternate methods for inferior alveolar nerve block, and let us quickly run through the various other techniques for anesthetizing the inferior alveolar nerve. One is the Clark and Holmes technique, which is a pretty old one, which was described in the year 1959, and it is a modification of an indirect technique. And this technique involves specific adjustment to improve the effectiveness and reduce the complications associated with the traditional inferior alveolar nerve block. And the key features include the higher injection site. So this technique requires the deposition of the anesthetic solution at a higher level than usual. And by aiming at a higher level, it seeks to enhance the likelihood of effectively targeting the inferior alveolar nerve and its branches. And also, it is an indirect approach. So the technique is termed indirect because it modifies the angle and positioning of the needle to optimize the anesthetic delivery without the direct visualization of the nerve. And what are the advantages? The adjustments in the injection site can be potentially lead to more consistent anesthesia of the mandibular teeth and surrounding tissue. Now let us see the technique. The needle is advanced from the opposite side of the mouth, specifically from between the premolars and the opposite side of the mandibular arch. And the height of insertion, unlike the standard indirect technique, the insertion point is just above the fingernail of the index finger, which is placed on the inner side of the ramus rather than the standard indirect technique. And one, as usual, as I have already mentioned, you need to come in contact with bone, and then the local anesthetic is deposited at this higher level, ensuring better coverage of the inferior alveolar nerve. There again, slow injection, 1.2 to 1.5 ml, and upon withdrawing the needle, the anesthetic may also anesthetize the lingual nerve, providing additional numbness to the tongue and the additional the adjacent soft tissue. And these modified Clark and Holmes technique approach aims to improve the effectiveness of the nerve block while addressing variations in the mandibular anatomy and the nerve positioning. Very, very important technique to anesthetize the inferior alveolar nerve is the Gaugate's technique. When your conventional inferior alveolar nerve block anesthesia does not work, or if there is any anatomic variations, use this technique, which will be very, very successful. And technique is also very simple. I won't call it simple, rather comparatively easy. And it is again an intraoral approach for the mandibular nerve. What are the nerves anesthetized? The inferior alveolar, the mental nerve, the incisive nerve, the lingual, myloid, auriculotemporal, the long buccal nerve are all anesthetized. So you don't need multiple injections, and that is a key feature of this Gaugate's technique. And also, it is a true mandibular nerve block that provides comprehensive anesthesia by targeting the mandibular nerve as it exits the foramen ovale. And also, it offers a high success rate due to its placement at a higher point, blocking multiple nerves in one injection. That's a point to be noted. Blocking multiple nerves in one injection. So also. It requires a greater precision, but can cover all areas innervated by the mandibular nerve branches, making it an ideal extensive for surgical procedures. So it's a very important technique. As you can see in the image, the point where you deposit the anesthetic solution, and the areas anesthetized are complete anesthesia of all teeth on the side of the block from molars to incisors. Yes, of course, like the inferior nerve block, it's a complete anesthesia, and the buccal soft tissue adjacent to the mandibular molars and the lingual gingiva across the lower jaw are also anesthetized. Sensory loss on the anterior 2/3 of the tongue, making and you will not be able to have any sensation in the anterior 2/3 of the tongue as well. The floor of the mouth is also anesthetized. The skin over the cheekbone or the zygoma, the posterior portion of the cheek also anesthetized, and there is a sensory loss over the skin of the temporal region extending to the external ear because the auricular temporal nerve is also anesthetized. So this comprehensive coverage makes the Gaugate's technique highly effective for extensive surgical or dental treatment within the mandibular region. And I guess this I've already mentioned in my earlier slides, and very, very important point to note is that the contraindication, if there is infection or acute inflammation at the site, and also in young patients it is contraindicated. And also if the inferior alveolar nerve block is unsuccessful, you can go in for a Gaugate technique. What is the target area? Now coming to the technique. The target area is the lateral side of the condylar neck below the insertion of the lateral pterygoid muscle. Locate the external landmarks and visualize the intraoral landmarks, and the area of insertion will be at the mucous membrane of the mesial of the mandibular ramus from the intertragic notch to the corner of the mouth just distal to the second molar. Noted that the intertragic notch to the corner of the mouth just distal to the maxillary second molar. And the needle tip is positioned below the mesiopalatal cusp of the maxillary second molar to establish the correct height of the injection. Note this point very carefully. The needle tip is positioned just below the mesiopalatal cusp of the maxillary second molar to establish the correct height of the injection. And the depth, approximately 25 millimeters, it should hit the neck of the condyle, ensuring that the anesthetic solution is deposited at the proper target area near the lateral side of the condylar neck. And this technique, as mentioned earlier, targets the mandibular nerve effectively by using both the vertical and the depth positioning, increasing the success rate of the block for comprehensive mandibular anesthesia. What are the approximating structures? It should be just inferior to the condyle, inferior to the attachment of the lateral pterygoid muscle, and the injection site is located below the lateral pterygoid muscle where the nerve lies, ensuring proper anesthetic deposition. And just mentioning a couple of complications here. Hematoma, because in case if the needle punctures the blood vessels near the target area. Trismus, muscle stiffness or limited jaw movement could result from inadvertent needle placement near the muscles of mastication. And also the facial palsy, if the temporary facial paralysis can occur if the anesthetic is deposited too deeply into the parotid. And avoiding complications, as you all know, by using a proper technique and anatomical knowledge are very, very important to minimize the complications. This is again another modification of the direct technique, the Angelo-Sargenti technique. It is a variation of the direct approach for nerve block anesthesia where the nerve is accessed from a higher point than in traditional technique. Just for completion's sake, I have included these techniques, and higher approach, the nerve is targeted from a higher level, providing a broader anesthetic effect, and it is particularly for difficult cases or when standard techniques are less effective. And the index finger is positioned at the retromolar fossa with a nail facing lingually, helping to guide the needle for accurate injection and ensuring proper angulation during the injection. And this modified technique allows for effective anesthesia in areas that might otherwise be difficult to reach with a standard nerve block technique. And the technique is that the needle is inserted opposite to the midpoint of the fingernail and slightly beyond the tip of the index finger, placed at the retromolar fossa. The barrel is placed between the upper premolar of the opposite side of the mouth and maintained in contact with the teeth throughout the procedure. Needle is then advanced slowly in a downward and backward direction, moving towards the bone, and the bone is typically contacted at the depth of about 1 centimeter, ensuring that the anesthetic is deposited at the correct target site, as you can see in these images. As again, for completion's sake, there is a new technique, another technique, the arched or a curved needle technique. And what is the advantage of this technique is that it enables clinicians to reach areas that would be difficult or impossible to access with a straight or unbent needle, improving accuracy and success rates for nerve blocks. And the arched needle technique enhances the overall efficiency of dental anesthesia, particularly in challenging cases involving the mandibular region. But when you use this technique, you have to be careful to avoid needle breakage. It can happen at the hub. So, coming to another very important, not very oftenly used, but then very important technique, the Vazirani Akinosi or the closed mouth technique. The indications include where there is a limited mandibular opening or trismus. When there is a restricted jaw movement, your traditional techniques like your conventional inferior nerve block or your Gaugates will not be possible. And also, when you are unable to visualize the landmark for the other traditional techniques. And there are disadvantages for this technique as well. Difficult to visualize the depth of injection. It is again a blind procedure, and challenges in patients with white flaring ramus, because this technique may be less effective in such patients, complicating the needle placement. And in patients with pronounced zygomatic ridge also, there will be prominent zygomatic ridge or pronounced internal oblique ridge, which can hinder the effectiveness and accuracy of this technique. What are the landmarks? The occlusal plane of the occluding teeth, the mucogingival junction of the maxillary molars, anterior border of the ramus. These are the anatomic landmarks. And the needle is positioned parallel to the gingival margins of the maxillary teeth or along the alveolar ridge in the edentulous patients. And this alignment is important for ensuring accuracy of the deposition of the anesthetic solution. By targeting this specific area, the needle can be effectively reaching the pterygomandibular space where the inferior alveolar nerve or the other branches are located, facilitating successful anesthesia for the procedures involving the mandible. Now, we'll go on to another technique, which is an indirect technique, Fisher 1, 2, 3 technique. There are 3 steps involved in this: step A, step B, and C. Step A will involve the syringe positioning, where the barrel of the syringe is positioned to rest on the occlusal surface of the opposite premolars. This provides stability and reference point for the injection. And the needle tip is placed on the external oblique ridge at the midpoint of the thumbnail, and this ensures accurate alignment with the targeted anatomical structures. And then you advance the needle 6 millimeters to 8 millimeters into the tissue, and this depth is sufficient to reach the area where the long buccal nerve can be effectively anesthetized. A few drops of local anesthetic solution are deposited at this point for successfully blocking the long buccal nerve, providing anesthesia to the buccal mucosa, and also for a painless injection. And step B, the barrel of the syringe is withdrawn slightly and then shifted to the same side. And this movement allows the needle to glide over the temporalis tendon, positioning it closer to the internal oblique ridge. Advance the needle to further 8 to 10 millimeters, and this depth is essential for reaching the lingual nerve while ensuring that the syringe barrel remains parallel to the mandibular plane. And the by maintaining this orientation and depth, this technique successfully blocks a lingual nerve, providing anesthesia to the lingual mucosa and ensuring patient comfort during the procedures. Next is the third step. The barrel is positioned over the first premolar on the opposite side again. That is, you swivel the barrel to the opposite side, and then the needle is advanced 12 to 15 millimeters until the bony resistance is felt. This indicates that the needle tip has reached the target area for the block. And then, as usual, deposit 1.2 to 1.5 ml for the inferior alveolar nerve. Where do you check for anesthesia for the inferior alveolar nerve, lingual nerve, and for the long buccal nerve? For the inferior alveolar nerve, take a sharp instrument, can be a probe or a periosteal elevator if you are doing a extraction procedure. Try to press it between the 2 premolars, the roots of the 2 premolars. That is where you check for anesthesia for the inferior alveolar nerve, where the inferior alveolar nerve exits as the mental nerve. As it enters into the mandibular foramen and it exits through the mental nerve, it is an intra-bony course. You will not be able to check for anesthesia anywhere else for the inferior alveolar nerve. Then for the lingual nerve, likewise, check in the lingual soft tissue for the lingual nerve. Long buccal nerve, of course, posterior buccal mucosa to the first molar. These are all objective findings that you find out as a dental surgeon. What are subjective symptoms? These are signs. Symptoms are the one which the patient tells you following an injection, that following inferior alveolar nerve block, that one half of the lip has got a tingling sensation, or they will tell you that the lip is kind of getting swollen. Basically, it is not getting swollen, but then they will basically tell that it is getting swollen. And the tongue, anterior 2/3 of the tongue, one half of the tongue, the patient will indicate that there is some tingling sensation or getting numb. These are the subjective symptoms what the patient tells you, and the objective signs are what you elicit. And to reiterate what I mentioned, the ideal place for checking anesthesia for inferior alveolar nerve block is between the roots of the soft tissue, between the roots of the two premolars, where the mental foramen axis is located. Next, we'll go to the extraoral mandibular techniques like a bronze technique, and the extraoral inferior nerve block technique utilizes the specific anatomic landmarks, including the midpoint of the zygomatic arch, the zygomatic notch, and the coronoid process of the ramus, and lateral pterygoid plate at a depth of approximately 4.5 centimeters. By pinpointing these landmarks, dental professionals can accurately administer anesthesia to the inferior alveolar nerve, ensuring effective numbness for any dental procedures. And this technique is particularly useful in situations where intraoral access is limited, or when deeper or longer lasting anesthesia is required. And palpate the zygomatic notch. Local infiltration should be given prior to the nerve block, the identified area, to minimize discomfort associated with the injection. And heavy gauge needle with a minimum length of 8 centimeters, a long needle is essential, and that needle is also marked to indicate the depth of 4 centimeters to ensure precise positioning for delivering the anesthesia to the targeted nerve. And then the needle is inserted little below the zygomatic process at the right angle to the skin, continuing until reaching the lateral pterygoid plate at a depth of approximately 4 centimeters. And after reaching the lateral pterygoid plate, the needle is withdrawn and reinserted a few degrees further distally to pass behind the posterior border of the lateral pterygoid plate. And it is essential to ensure that the needle is not penetrated more than 5 centimeters to prevent potential complications. Now we have seen the other all the techniques for the mandibular anesthesia. I would like to highlight a few points in particular to the other specialties, endodontics, pediatric dentistry, and prosthodontics, periodontics, where as certain modifications to the procedures, to the technique can be done to ensure proper anesthesia. In case if there is a inflamed tissue, inflamed pulp, or a localized infection, most of the endodontists go through these issues. So how to achieve anesthesia? Rather than depending on a local infiltration, give a block at distant site of injection. And also the articaine can be used, and the buffering of local anesthetics with bicarbonate can be used, and also inhalation sedation can be used to keep the patient very comfortable. Supplementary injections like intraosseous injection techniques or intraseptal injection techniques, or a periodontal ligament injection technique, or an intrapulpal can be used to achieve anesthesia. Sometimes the patient, your block will be working perfectly all right, and when you open a root canal, and as you go near the pulp, the patient will have severe pain because of the inflamed pulp. In such situations, give an intrapulpal injection. This is an intraosseous injection. Apply topical anesthetic. Prepare a small perforator hole into the cortical plate. Push through the attached gingiva till the tip rests on the bone, and inject LA into the hole, into the bone to achieve intraosseous injection. Intraseptal, soft tissue anesthesia by local infiltration. A 27 gauge needle can be used, and in the intraseptal bone, and you just require 0.2 cc of anesthetic. There will be resistance when you inject intraseptally, and you can see the blanching of the intraseptal region. Periodontal ligament, again you can use a 27 gauge short needle, and insertion is between the interproximal bone and the tooth to be anesthetized, and always remember the bevel should be facing the tooth, and 0.2 cc of local anesthesia is sufficient enough. Intrapulpal, as I mentioned earlier, inflamed tissue. It provides pain control both by the pharmacologic action of the local anesthetic and by applied pressure. This technique may be used once the pulp chamber is exposed completely after the RC opening. And also you can use cotton pellets with the local anesthetic. Wait for 30 seconds, press it firmly into the pulpal floor, wait for 2 or 3 minutes and till you achieve the local anesthesia, and use a slow speed, high torque handpiece to reach the pulp. That is again a very important point to note. In pediatric dentistry, as you know, anxiety, poor pain control, or a previous unpleasant experience will not allow the child to be cooperative. Also, have a note on local anesthetic overdose. You need to calculate and give the dosage accordingly to the age and weight of the patient. And also, due to prolonged anesthesia, you can have a self-inflicted soft tissue injuries. Also, you can have anatomical abnormalities as I explained previously about the position of the mandibular foramen. And the maximum recommended dose 0.9 to 19.3 milligram per kg body weight in a patient who's 13 kilograms in weight and 2 years. And also, if the age of the patient is 5 and if they weigh 20 kilograms, then the range is 0.9 to 12.6 milligram per kg body weight. And also, if the age is 10 and they weigh 35 kilos, it can be 31 to 7.2 milligram per kg. As I mentioned earlier, the self-inflicted trauma to lip and tongue due to prolonged soft tissue anesthesia. And how do you prevent it? Local anesthetic with appropriate duration of action can be given, a short-acting local anesthetic. Phentolamine mesylate, it is a alpha-adrenergic antagonist to reverse local anesthetic solution, can also be given in children, and educate the patient, that is again, educate the parent to keep an eye on the kid, eye on the child to avoid these complications. And the techniques, the maxillary anesthesia, give a supraperiosteal injection, and attempt posterior superior alveolar nerve block in case of increased bone thickness buccal to the first molar. Nasopalatine and retropalatine block or accessing invasion palatal nerves or widely flat palatal roots can be given, and also intrapapillary injection can be considered in pediatric dentistry. As far as the mandible is concerned, again, supraperiosteal infiltration, the inferior alveolar nerve block, and you can have a greater success than adults if you use a short needle. And also if you want to try Gaugates or Vazironi, whenever indicated, use a short needle in children. Incisive nerve block can be very effective, and also try a periodontal ligament injection. In periodontics, the techniques, whatever has been described earlier, like the mental nerve block or the inferior alveolar nerve block or the long buccal or Gaugates, can be used. But then if you use local anesthetic with adrenaline, you will get a good hemostasis. As periodontists, most of them deal with soft tissue procedures, and risk of late post-surgical bleeding with adrenaline due to rebound vasodilation also is a possibility. And can also use articaine if you need a clearer surgical field than lignocaine, and if you want to avoid adrenaline, because articaine itself provides vasoconstriction to a certain degree. In oral maxillofacial surgery, it goes without saying that general anesthesia does not prevent pain or prevents patient's response to pain, but even under general anesthesia, you give local anesthetic solution to avoid postoperative pain, and also to have a clear surgical field, in addition to the general anesthesia. During general anesthesia, your blood pressure, heart rate, and respiratory rate increase on surgical stimulation, and also administration of local anesthesia reduces the exposure to general anesthetics. And also residual local anesthetic can be given for post-surgical pain control, and a long-acting local anesthetic like bupivacaine can be used, and post-surgical pain management can be done with NSAIDs, and preoperative administration of NSAIDs also can be given to delay a post-operative pain. And lastly, for our prosthodontic colleagues, you do vital tooth preparation, which will require a local anesthetic solution. Technique. And irritation to pulp due to tooth preparation will also require. And for any other secondary procedure, local anesthetic will be mandatory. And consider giving a nerve block in case of full mouth preparation. And thank you for patient listening to this session on mandibular techniques in local anesthesia for the course on NPTEL, course on local anesthesia for clinical dental practice. And I conclude by mentioning all my references that have been used for my presentation. Thank you and happy learning.